The ankle drawer test evaluates the integrity of the anterior talofibular ligament, which is the most frequently injured ligament in lateral ankle sprains. There are three stabilizing ligaments on the lateral side of the ankle. The most vulnerable and most commonly injured is the anterior talofibular ligament, spanning between the talus and fibula. The next most commonly injured is the calcaneofibular ligament. If the injury is very bad, there may also be damage to the posterior talofibular ligament, although this is nowhere near as common. The motion of the ankle that makes it most vulnerable to sprain is inversion, especially if it's combined with plantar flexion. We're going to begin with the client's foot off the end of the table. The anterior talofibular ligament is running right here between the fibula and talus. So one hand is going to stabilize the distal tibia, the other hand wraps around the back side of the ankle. I'm going to give a firm upward pull straight up on the posterior side of the calcaneus back here while firmly holding the distal tibia. So give a nice firm pull upwards, and it feels good and stiff because this is a healthy ankle. If the ligament was injured, there could be a mushy infeel. This could cause pain out here, or there could be forward translation of the foot visible. Notice when I do this, there's a slight degree of dorsiflexion of the foot. Don't mistake that for the forward translation of the foot, which you'll actually notice as a shifting of the foot up in this direction. It may even be slightly visible. Any forward translation of the foot or movement up in that direction could be indicative of injury to the anterior talofibular ligament. The talar tilt test is another method for evaluating injury to the lateral ligaments, and this one emphasizes the calcaneofibular ligament. The calcaneofibular ligament goes between the fibula and the calcaneus right down here. For this test, the client's foot again is off the end of the table. Place both thumbs on the lateral side of the foot and the fingers are wrapped around the medial side, and we're simply going to push the foot into inversion, straight inversion, and see if it reproduces the client's pain or there's a mushy end feel with this movement. The pain is likely to be felt right out in the lateral ligament ankle structures, and the foot will feel somewhat unstable in this position. The talar tilt test is another way to look at an injury mainly affecting the calcaneofibular ligament. The squeeze test is used to evaluate the integrity of the tibiofibular syndesmosis ligaments, which may be injured in a high ankle sprain. A tight webbing of ligaments binds the distal tibia and fibula together. This fibrous connection is called the distal tibiofibular syndesmosis. Overstretching and strain to these tissues usually occurs from the extremes of dorsiflexion, rotational stresses on the ankle, or a combination of both. For this test, position your client's leg so that it can be in a partially flexed position. And the distal tibiofibular syndesmosis is down in this location here, and what we're going to do is squeeze and press those two bones together, and this also puts stress on the joint structure and may cause pain sensation to be felt in the distal tibiofibular region. When I apply that pressure there, note where the pain is felt. If it is felt down in this region here, that could be indicative of injury to the syndesmosis ligaments. But pressure applied straight across here could also cause some discomfort with other conditions like a compartment syndrome or shin splints that are more soft tissue injuries. If the pain is felt in the shin region where I'm pressing, that would be less indicative of the syndesmosis injury. The ligament injury would be more likely if pain is felt down here in those ligament structures around the ankle. Identifying injury to the syndesmosis ligaments is a valuable means of determining our most appropriate method for treating those particular disorders. The external rotation stress test is another effective method to test the integrity of the tibiofibular syndesmosis ligaments. In this procedure, stabilize and hold the distal tibia with one hand, and with the other hand wrap it around the back side of the calcaneus so that you can turn and rotate the foot. There's not a great deal of range of motion here, but rotate the foot externally as far as the range of motion allows. If pain is reproduced, up in the upper ankle region up here with this test, this is indicative of potential injury to the syndesmosis ligaments. The pain will usually be felt right at the end of that rotation as the talus is spreading apart the tibia and fibula with the rotary movement. And this could be pain felt up here as opposed to lower down in the foot and ankle complex from one of the other stabilizing ligaments around the side. The syndesmosis ligaments are significantly higher up in there, rotating externally, and that would reproduce the client's pain. The syndesmosis sprains are different in their location and sometimes harder to pick up, so this test can be very helpful in that process. The Morton's test is used to determine if there is adverse pressure on the plantar nerves between the metatarsal heads, indicating the possible existence of a neuroma. On the medial side of the ankle, the tibial nerve divides into the medial and lateral plantar nerves. These nerves course along the plantar surface of the foot and have distal branches that innervate the toes. Both the medial and lateral plantar nerves are susceptible to compression between the metatarsal heads in the distal foot. Compression of the plantar nerves is aggravated by tight footwear, as well as certain foot positions during the extremes of toe extension that occur during the push-off phase of gait. For this test, come down into a squatting position so that you can apply pressure to each side of the metatarsals and push straight inward. As we push straight inward, you want to make sure that you don't accentuate the transverse arch across the foot this way, but the pressure comes straight across and squeezes the metatarsal heads together. Once you put that pressure on there, identify if there is pain or discomfort into the third and the fourth toes or immediately in this region between the metatarsal heads. That would indicate the possible existence of a neuroma or compression of those plantar nerves between the third and fourth metatarsals. The interdigital squeeze test also evaluates for adverse pressure on the plantar nerves and is valuable to perform in conjunction with the Morton's test for additional clarification. For this test, you're going to apply pressure to both sides of the foot and press on the region in between the third and fourth metatarsals. On the underside of the foot, with the thumb, press here between the third and fourth metatarsals. On the top side of the foot, we'll press here with the fingers between the third and fourth metatarsals. So squeezing them together, we're going to try to identify if this produces pain, and this is most likely to be a sharp shooting neurological pain into the third and fourth toes. So that would be felt right up in here or on the bottom surface of the foot, right up into this region here. So again, with the squeeze, we press in there, and if this produces a sharp neurological sensation right in that area, that could be indicative of additional pressure of the plantar nerves between the metatarsal heads. The bone percussion test, while not considered highly accurate, can provide some additional information about the possible existence of a stress fracture. When you have lower extremity overuse injuries, it's a good idea to determine if the pain or discomfort may be coming from overuse problems in the soft tissues, but a stress fracture could be possible. Simply tapping directly on the bone where the pain is felt can sometimes give greater help in indicating the possible existence of a stress fracture. If you tap on the bone and pain is felt directly in this area underneath where you're tapping, it's more likely that there could be bone involvement like a stress fracture as opposed to some overuse injury in some of the muscles such as the tibialis anterior. This is not considered necessarily a highly accurate means of identifying the presence of a stress fracture, but to help you rule out stress fractures versus soft tissue involvement, it can be a useful piece of information. The dorsiflexion eversion test is valuable for identifying adverse compression of the tibial nerve or its branches near the tarsal tunnel, which is often mistaken for plantar fasciitis. The tarsal tunnel is located on the medial side of the ankle under the flexor retinaculum. The tunnel contains tendons from the deep posterior compartment muscles, the tibial artery and vein, as well as the medial and lateral plantar nerves. The tibial nerve divides into the medial and lateral plantar nerves just as it enters the tunnel. Nerve compression in the tunnel usually occurs from overuse in various activities, along with dysfunctional foot mechanics. For this procedure, come down and get in a position where you can move your client's foot into dorsiflexion. And all we're simply going to do here is move her foot into dorsiflexion and, as far as possible, move the toes into hyperextension at the same time. We're also going to slightly evert the foot, turning it out this way. What this does is pulls and stretches on the tibial nerve that's running through the tarsal tunnel. So we're going to hold this position for about 15 or 20 seconds. And if it produces neurological sensations either in the medial side of the ankle or into the bottom surface of the foot, that could be indicative of compression or adverse tension on the tibial nerve in the tarsal tunnel. So we'll hold that position, and if those symptoms are felt after that short a period of time, this could be indication of neurological involvement. It's an important thing to identify because a lot of times the nerve compression problems in this region are mistaken for plantar fasciitis with the pain that's felt on the bottom surface of the foot. The Achilles tendon pinch test helps discriminate between Achilles tendon dysfunction and other nearby soft tissue disorders, such as inflammation of the retrocalcaneal bursa. The Achilles tendon is the largest tendon in the body, and its distal attachment of the gastrocnemius and soleus muscles. The most distal region of the Achilles tendon has a very poor blood supply, and so is routinely the site of overuse dysfunction in the tendon. There are several other structures in this area, such as superficial and deep bursa, so it's important to discriminate between pain from the Achilles tendon and these other soft tissues. In this procedure, we're going to try to discriminate between pain on the backside of the heel that may come from Achilles tendon dysfunction and other pain such as the bursa that's just sitting back here that may become inflamed and cause pain in a very similar region. Taking both fingers, we're simply going to pinch on the sides of the Achilles tendon. And squeezing the tendon, we're trying to identify if this reproduces the primary pain the client has been complaining of. By pressing the sides of the tendon, we're no longer putting pressure back on the bursa that would be back here. If we pressed on the Achilles tendon straight down this way, either one of those structures could be painful, but simply pressing on the tendon from the sides eliminates the bursa so that only pressure is applied to the Achilles tendon. It's a good idea to test varying regions of the Achilles tendon, even though it is the most distal region down here where there's poor blood supply and most of the overuse dysfunction appears. Pressing all along the sides of it may give you valuable information about tenderness in different regions of the tendon. By pressing on that Achilles tendon, we can determine might we be having a problem going on with the gastroc-soleus, overusing those muscles and straining the Achilles tendon, as opposed to something such as retrocalcaneal bursitis causing the posterior heel pain. The Thompson test is used to assess a complete rupture of the Achilles tendon. If it's present, this condition should be referred to an orthopedist for further evaluation. In this test, we're going to look at a complete rupture, which actually could occur in the tendon tissue, the musculotendinous junction, or in the muscle tissue themselves. You might think that a person wouldn't be able to walk with this condition, but it's actually possible for other muscles to take over the function of the gastroc and soleus. In this test, all we simply do is squeeze the gastroc and soleus muscles and watch the movement of the foot. As long as her foot moves, as I squeeze these muscles, that's indicative of the tendon and muscle complex being intact. If there was a rupture in any of these structures which completely disrupted their continuity, when I squeeze these muscles, you wouldn't be able to see any movement occurring here in the foot. If there is a rupture in these structures, obviously this would need to be referred to an orthopedist for further evaluation, but it is something a massage therapist should be aware of. The tibialis posterior compression test is a valuable way to evaluate for overuse of the tibialis posterior or other deep compartment muscles. The tibialis posterior lies deep in the posterior compartment on the back side of the leg. In the midst of activity, there's a constant tensile load on the proximal attachment sites along the posterior tibia and fibula. A constant tensile load over a broad area can cause irritation to the periosteum and produce the characteristic discomfort known as shin splints. The deep compartment muscles are difficult to access, but they're located just on the medial border of the tibia, right along through here. So with this procedure, just simply take your fingertips and wrap them as far as you can back around the back side of the tibia and apply pressure straight into this region. If the pressure, when you apply it, reproduces the primary pain the client has been experiencing, there's a good chance that there's involvement of the tibialis posterior or one of the other deep compartment muscles. So simply take the fingertips, wrap them around the back side of the tibia, and make sure the pressure is applied into the soft tissues and not directly against the bone, but into the soft tissues back in that posterior compartment. Wrapping your fingertips in there. This will be a way to indicate if this is involvement of the tibialis posterior muscle tendon unit. Once we've identified potential problems with the tibialis posterior, now we can begin to make some strategies for how best to treat problems with those deep posterior compartment muscles.